So the principles of pharmacology. So with pharmacology, you need to know these drugs. What is the reasons for these drugs? Why do we use them? When the most important thing is when do you not use them? So you can't be giving them to patients that don't qualify for their use. As an EMT, you're allowed to do peer, patient, or EMT administered medications. So you can give your peers a Tylenol. Patient assisted means if they are already prescribed a medication, you can assist them in taking their prescriptions. And EMT administered would be if you carried an EpiPen on your truck and you administered to that patient, but it wasn't prescribed to that patient, that is you administering it. Your protocols, which are offline, are going to tell you offline med control, what you can and can't do. But then you also have the option to call med control and get permission to do something, which would be online med control. Failure to administer medication safely can lead to consequences and automatic life threats. Medications work. So pharmacology is the study of drugs. Medication is the actual drug or the substance used to prevent or treat disease or relieve pain. And pharmacodynamics is how does that drug work within that body. Okay, if you remember during A&P, we talked about the liver is responsible for breaking down drugs. And so you may be prescribed 10 milligrams of metoprolol. Your body's only actually getting 2 milligrams of that because 8 milligrams is processed by the liver and just destroyed and never makes it to your bloodstream. Therefore, keep that in mind when administering medications to a liver patient or a liver failure patient, that they might not require the same doses as a normal person. Terminology you need to be familiar with. Agonist stimulates receptors. So agonist stimulates. An antagonist blocks it. So Narcan is an antagonist. Narcan gets onto the opiate receptors and keeps the opiates from being able to stimulate. So it blocks the opiates. Dosage are based on age or weight. The action is what is the effect that that drug has on the body? What is its action? What does it do? Indications for a drug, what are the reasons to administer it? So high blood pressure is an indication for a hypertensive medication. Anaphylactic is an indication for an EpiPen. Overdose is an indication for activated charcoal. Contraindications. When would I not administer this to a patient? Well, obviously allergies is a contraindication for all medications. If the patient's allergic to it, I'm not going to give that to them. But there are some specific contraindications, kind of like CPAP had a contraindication of low blood pressure or unconscious patient. I cannot give CPAP to a low blood pressure patient or an unconscious patient. Side effects would be effects that are not intended, but they're going to happen, but they're not necessarily life-threatening. Names. You have your generic versus your trade. Your generics are always lowercase, and they're non-proprietary. So ibuprofen versus Advil, acetaminophen versus Tylenol. Trade names are proprietary, and they have typically start with capital. So the biggest thing is if you see one with lowercase, it's generic, and if you see one with uppercase, then it is going to be your trade names. You have prescription drugs, you have over-the-counter medications, recreational, herbal, illegal, vitamin supplements. These are all medications. 6 rights you should always check before administering a medication. Is it the right drug? Is it the right dose? Is it expired or the right date? Is this the right patient I'm giving it to? Is it meant to be oral? Is it meant to be nasal? So right route, and make sure you document correctly on your reports. 6 rights you have to do for every patient before you administer a drug. The routes to administer. So enteral versus parenteral. Here we go into the medical terminology. So enteral, if you look at the ENTER, that means intestines or the digestive system. So if I'm administering something via the enteral route, it's going through the intestines. If I administer something through the parenteral route, per means going around, parameter. So we're not going through the digestive system. The slowest route is going to be going through the digestive system, and the fastest routes are going to be found not going through the digestive system. So absorption is the process by which the medication gets to the bloodstream. Enteral medications enter through the digestive system. It's a slower process. Parenteral medications enter the body through breathing it in, so inhalation, being administered through an IV, being administered like an EpiPen is IM. Okay, those are parenteral. They're going around the digestive system. Medication forms, so they come in many forms. So you need to know the difference between tablets and capsules, solutions and suspensions, metered dose inhalers. Transcutaneous medications would be like your patches that you see people wearing. Gases, the most common we use is oxygen for inhalation. Tablets versus capsules. So tablets are solid. Capsules come in a covering that can be pulled apart that has the medication inside them. A solution versus a suspension. A solution doesn't separate, so it doesn't have to be shaken before you give it to them. Whereas a suspension, there's particles suspended in that, and it typically will require you to shake it up before you administer it to a patient. Metered dose inhalers, it gives a specific dose every time you push it. The ones that are used in an ambulance that are used on multiple patients have a spacer that is put in between the patient and the metered dose inhaler so they don't get anything directly on the metered dose inhaler. Again, check your 6 rights: right drug, right patient, right dose, right date. Make sure it's not expired before you administer that. Gels would be like the instant glucose we carry on an ambulance to administer sugar to our diabetic patients. Topical and transcutaneous. So transcutaneous is going through the on the skin surface. So cutaneous stands for skin, and topical is like your lotions and stuff. Transcutaneous or transdermal is your patches. And then your gases, the most common one we administer is oxygen. Here's your drugs now. So these are the drugs that you have to know. So activated charcoal. This is given during overdose patients. It's designed to go into the stomach and absorb whatever they had overdosed on so that it doesn't go through the liver and the digestive system. So it cannot be absorbed in the body. The route is oral. The dose is 1 milligram per kilogram. When do you give it? Any overdose that's happened within an hour. And the contraindication, when would I not give it? Since it's an oral medication, I'm not going to give it if my patient has an altered mental status because I don't want them to aspirate. If they have any signs of an acidic or an alkali or petroleum overdose, that they swallowed something acidic, alkali, or petroleum, we do not administer it because actually it getting into the stomach acids is going to dilute it a little bit. Plus, if we give them the charcoal, they're at risk for vomiting, and we don't want that acidic substance coming back up through the esophagus and doing a second round of damage to the esophagus. Your oral glucose, it provides sugar to your cells so that it can start producing your ATP. This is another oral medication, or it can be considered mucosal because I can administer it underneath the patient's tongue or in their cheek if they're altered and I'm worried about them choking on it. If they're unconscious, I can't give it to them. So an unconscious patient cannot be given oral glucose. But if they're just altered or a little confused, I can put it in their cheek. 15 grams comes in 1 tube, and the indication would be low blood sugar. Aspirin, so I administer aspirin to any patients that are having chest pain, and the dose is 325, which is 1 adult aspirin, or 4 baby aspirin, which are 81 milligrams each. That one's going to be 324. When do I administer this in the field? Only during chest pain patients. If they're complaining of chest pain, they get 325 or 324 aspirin. I cannot give it if they have asthma or any signs of bleeding. Okay, so this is a prevents platelet aggregation. What that means is it prevents a clot from getting bigger. It won't thin the blood, as in it will not break down clots that already exist. It strictly prevents the clot from getting bigger. So you take this platelet that is really sticky. It's a sticky cell that floats around and sticks to injuries in the body. When you take aspirin, it takes that platelet and it buffs it out so that it's really smooth. So it will just slide past instead of sticking onto clots that already exist. And that's the way that it works. Make sure they have not taken an aspirin within the last 12 hours, otherwise you cannot administer it to them. Nitro. Nitro is also given to our chest pain patients, but they have to be prescribed the nitro. We do not administer our own nitro as an EMT, and we do not administer somebody else's nitro to a patient as an EMT. Has to be prescribed to them within date. It's sublingual, goes underneath the tongue, so it has a mucosal. It absorbs into the mucosa. The dose is 0.4 milligrams or 1 spray or 1 tablet underneath the tongue. You can repeat it up to 3 times, but you need to take their blood pressure, because one of the things it does is it dilates the coronary arteries. So it'll take this artery that is normally, let me get my pen out, we'll say it's normally, under the circumstances, it's got that big of a diameter. And you have a clot in here that's causing the heart attack. Okay, you give them nitro and it dilates that artery. So now that clot is still attached over here, but I have a much bigger space to perfuse the coronary blood vessels now, much bigger space to perfuse the heart. So it's a vasodilator, which means if I make this container bigger, think about this when we talked about shock. I have a glass and it's full, right? If I take this same glass and I'm able to stretch it and make it wider, now same amount of fluid, but it looks like it's not full. That's what happens when the body vasodilates in anaphylactic shock or septic shock or any of those. Well, when a patient's blood pressure drops, which is going to happen when I give them nitro, their blood pressure is going to drop. So I need to check it and make sure their blood pressure always stays above 100. If their blood pressure is below 100 on that first number, they do not qualify for any more nitro. And I need to see if they're taking any erectile dysfunction meds, Viagra, Cialis, or Levitra in the last 24 hours. The reason for that is because these drugs also cause vasodilation. And so I risk dropping the blood pressure really low if the patient has already taken any of those medications within the last 12 to 24 hours. Side effects would be like a headache, because I'm vasodilating the blood vessels in the brain too, which can give us a headache. Make sure your patient's laying down or sitting down so that if it does drop their blood pressure, they don't pass out. Remember, this is done 1 spray or 1 tablet underneath the tongue up to 3 times every 5 minutes. And you need to take a blood pressure every time before you administer it. EpiPens, you have pediatric and you have adult, 3 milligram for adult, 1.5 for pediatric. This is going to cause a vasoconstriction, increased heart rate, and dilates the bronchioles. So when we talked about anaphylaxis, we said that blood vessel goes from this to this. Well, epi creates a vasoconstriction and pulls it back to its normal size, which should help increase the blood pressure. It also increases the heart rate, because epi, also remember, your sympathetic nervous system is epinephrine or norepi. Well, you're pretty much giving them adrenaline dump. But it also dilates their bronchioles. So in their lungs, you had the bronchi that went down to the bronchioles that turned into the alveoli. Well, in anaphylaxis, those bronchioles constrict. And so it makes it hard to pass oxygen through to get them down to the alveoli for respiration of CO2 and O2 exchange. With epi, it opens these back up. And so I have more room for air to get down there. And that's with anaphylaxis. That's why they have the stridor noise and the swelling and all that. So it's given IM in the thigh. Hold it for 10 seconds before you remove it. Narcan is given in the nose. This is to reverse opioid overdoses. And how do you know somebody has opioid overdose? So if they're unconscious, snoring respirations, and you notice constricted pupils, that's the big sign for that your patient needs Narcan. Just know that Narcan can in turn also cause seizures, vomiting, or aggression because you're taking their high away. If they are an addict, this could be really dangerous. But let's not even just go to addicts. What about these cancer patients that are on high-dose morphine? If you turn around and gave them all the Narcan and took all of their pain management away, you're going to throw this patient into significant pain. It's 1 ml in the nostril through a MAD device. That's called a MAD device, mucosal atomization. So it basically creates a spray, so it's easier for it to absorb in the mucous membranes. Naloxone is the other name for it. And then you have oxygen. Again, we give that for hypoxia, dyspnea, hypoperfusion, or signs of shock. Our routes are bagged, BVM at 15 liters, nasal cannula 2 to 6, or non-rebreather 10 to 15. And don't use it around open flames, cigarettes, or sparks. Albuterol is administered in a nebulizer. It could also be a metered dose inhaler. But with this, we break open the little capsule and we pour the albuterol into that. You hook it up to an oxygen, and it's typically 7 liters per minute. So it can't just be at the little 2 liter. It's got to be about 6 to 7 liters a minute to actually create the mist for them to inhale it. Coach them into taking deep breaths to get that medication all the way down the bronchi, into the bronchioles, out to the alveoli. So if they're taking short, shallow breaths, that medicine's not getting passed up here. And I need the medicine down here. Know some of the common names, Proventil and Ventolin. Now, albuterol will cause nervousness, tachycardia, tremors. They'll be shaking. It increases their heart rate. Those are all normal side effects of albuterol. Medication errors. If you make a medication error, you just need to admit you made one. If you if a medication error occurs, provide appropriate patient care, notify med control, document it accurately, and talk with your supervisor. When you make medication errors happen, it's not a big deal unless you try to cover them up. How do you prevent them from happening? Be aware of your equipment. Make sure you're checking to make sure your drugs are not expired. Limit your distractions. Have good lighting. Have your partner check the drug before you administer it. So you look and make sure the date and everything is good. Make sure your dose is good. Have your partner do a double check for you. Make sure you know these drugs, guys, inside and out.